Welcome to NGN NCLEX case study for end-stage renal disease with peritoneal dialysis review. For clients who are experiencing acute kidney injury or chronic kidney disease, dialysis can sustain life, although it does not replace the hormonal function of the kidney. The two types of dialysis are hemodialysis and peritoneal dialysis. The functions of dialysis are: rids the body of excess fluid and electrolytes, achieves acid-base balance, eliminates waste products, restores internal homeostasis by osmosis, diffusion, and ultrafiltration. Hemodialysis shunts blood from the body through a dialyzer and back into circulation. Hemodialysis requires vascular access. Hemodialysis is based on manifestations, not the glomerular filtration rate. Indications for hemodialysis includes renal insufficiency, acute kidney injury, chronic kidney disease, medication or illicit drug toxicity, persistent hyperkalemia, hypervolemia that does not respond to diuretics. Client presentation includes fluid volume changes, electrolyte and pH imbalances, and nitrogenous wastes. Manifestations include fluid overload, neurologic changes, bleeding, and uremia, cognitive impairment, pruritus, nausea, vomiting. For the purpose of this case study, we will focus on peritoneal dialysis. Peritoneal dialysis involves installation of hypertonic dialysate solution into the peritoneal cavity and subsequent dwell times. Drain the dialysate solution. That includes the waste products. The peritoneum serves as the filtration membrane. The client should have an intact peritoneal membrane, without adhesions from infection or multiple surgeries. Indications: peritoneal dialysis is the treatment of choice for the older adults who require dialysis. Peritoneal dialysis treats clients requiring dialysis who are unable to tolerate anticoagulation, have difficulty with vascular access, have chronic infections or are unstable, have chronic diseases, diabetes mellitus, heart failure, severe hypertension. Pre-procedure nursing actions includes: assess dry weight, without dialysate installation, vital signs, blood electrolytes, blood creatinine, BUN, and blood glucose. Determine the client's ability to self-perform peritoneal dialysis and follow sterile technique. Assess level of alertness, past experience with dialysis and understanding of procedure. Client education. Follow instructions regarding the procedure. Fullness can be felt when the dialysate is dwelling. There can be discomfort initially with dialysate infusion. Continuous ambulatory peritoneal dialysis, CAPD, requires 7 days per week for 4 to 8 hours. Clients can continue normal activities during CAPD. Continuous cycle peritoneal dialysis, CCPD, is a 24-hour dialysis. The exchange occurs at night while sleeping. The final exchange is left in to dwell during the day. Automated peritoneal dialysis, APD, is a 30-min exchange repeated over 8 to 10 hours while sleeping. Intra-procedure nursing actions. Monitor vital signs frequently during initial dialysis of clients in a hospital setting. Monitor blood glucose level. Dialysate is a hypertonic solution that contains glucose. Record the amount of inflow compared to outflow of dialysate. Monitor the color, should be clear, light yellow, and amount, should equal or exceed the amount of dialysate. Inflow, of outflow. Monitor for findings of infection, fever, bloody, cloudy, or frothy dialysate return, drainage at access site, and for complications, respiratory distress, abdominal pain, insufficient outflow, discolored outflow. Check the access site dressing for wetness, risk of dialysate leakage, and exit site infections. Warm the dialysate prior to instilling. Avoid the use of microwave ovens, which cause uneven heating. Adhere to the times for infusion, dwell, and outflow. Maintain surgical asepsis of the catheter insertion site and when accessing the catheter. Keep the outflow bag lower than the client's abdomen, drain by gravity to prevent reflux. Reposition the client if inflow or outflow is inadequate. Carefully milk the peritoneal dialysis catheter if a fibrin clot has formed. Provide emotional support to the client and family. Post-procedure nursing actions: monitor weight and blood levels of electrolytes, creatinine, glucose, and urea nitrogen, BUN. Client education. Perform home care of the access site. Perform peritoneal dialysis exchanges at home. Support can be provided with home peritoneal dialysis with home visits. Seek additional information from the National Kidney Foundation for local support groups. Follow instructions carefully and take all medications. Take essential minerals and vitamins with supplements of phosphorus, calcium, sodium, and potassium. Older adult clients can be unable to care for a peritoneal access site due to cognitive or physical deficits. Body image changes from bloating can be a concern. Complications. Peritonitis. Peritoneal dialysis can allow microorganisms into the peritoneum and cause peritonitis. Cloudy or opaque effluent is the earliest indication of peritonitis. Nursing actions. Maintain surgical asepsis during the procedure. Monitor for infection, fever, purulent drainage, redness, swelling, cloudy or discolored drain dialysate. Client education. Use strict sterile technique during exchanges. Notify the provider about any indications of infection. Another complication is infection at the access site. Infection at the access site can result from leakage of dialysate. Access site infections can cause peritonitis. Advanced age is a risk factor for access site complications due to chronic illnesses and/or fragile veins. Nursing actions. Maintain surgical asepsis at the access site. Assess the site for wetness from a leaking catheter. Monitor for infection, fever, purulent drainage, redness, and swelling. Client education. Use strict sterile technique during exchanges. Notify the provider of any indications of infection. Assess the site for leaks, and prevent tugging or twisting of the tubing. Another complication is protein loss. Peritoneal dialysis can remove protein from the blood as well as excess fluid, wastes, and electrolyte. Nursing action. Increase the client's dietary intake of protein over pre-dialysis restrictions. Monitor blood albumin levels. Client education. Follow the renal diet with an increase in dietary protein. Another complication is hyperglycemia and hyperlipidemia. Hyperglycemia can result from the hyperosmolarity of the dialysate. The blood can absorb glucose from the dialysate. Hyperlipidemia can also occur from long-term therapy and lead to hypertension. Nursing actions. Monitor blood glucose. Administer insulin for glycemic control. Administer antilipemic medication for triglyceride control. Client education. Check blood glucose. Follow the diet the provider recommends. Take antihypertensive medication for elevated blood pressure. Finally, the last complication is poor dialysate inflow or outflow. Causes include obstruction or twisting of the tubing, constipation, client positioning, fibrin clot formation, and catheter displacement. Thank you for clicking. If you like our contents, please like, share and subscribe for more videos. So let's begin. A 35-year-old female presented in the ED complaining of fever, vomiting, and abdominal pain that started 1 day ago. She was diagnosed with chronic glomerulonephritis 5 years ago. Chronic kidney disease progressed to end-stage renal disease, ESRD, over last year. Client was started on automated peritoneal dialysis 6 months ago. Current assessment in the admission note reads, temperature 39.1 Celsius, 102.4 Fahrenheit, heart rate 104, respiratory rate 16, blood pressure 145/87. Weight, 66.8 kg or 147 pounds. No known drug allergies. Periumbilical tenderness, defense and rebound. Erythema and creamy, yellow exudate around peritoneal dialysis catheter exit site. Dialysate effluent is cloudy yellow. Peritoneal effluent culture was obtained. Lab sent. Laboratory report are as follows: BUN 46, creatinine, serum, 10.7, C-reactive protein 61.5. Albumin 3.7, potassium, serum, 5.86. Sodium, serum, 144, calcium 7.9, phosphorus 5.8, hemoglobin 10.6. Hematocrit 31%, serum white blood cell 14.22 times 109 cells per liter, serum neutrophils 89.8%, dialysate white blood cell 483 cells per microliter. Dialysate polymorphonuclear cells 63%. Question 1. Which 5 findings are the most concerning? Temperature, heart rate, respiratory rate, blood pressure, periumbilical tenderness. Peritoneal dialysis catheter exit site. BUN, creatinine, serum WBC, or dialysate white blood cells 483 cells per microliter, dialysate polymorphonuclear cells 63%. Which 5 findings are the most concerning? Question 5 answers. The 5 findings are the most concerning are temperature, periumbilical tenderness, peritoneal dialysis catheter exit site, serum WBC, dialysate WBC. Rationale: fever, abdominal pain, elevated WBC in the serum and dialysate effluent are indications of peritonitis, a potentially life-threatening complication of peritoneal dialysis. Although the BUN and creatinine are high for an individual without renal failure, these values are typical of a client with end-stage renal disease on peritoneal dialysis. The blood pressure and heart rate are only slightly elevated, so are not a priority at this time. The respiratory rate is within normal range for an adult. Erythema and creamy, yellow exudate around the peritoneal dialysis catheter exit site indicate the possible presence of an exit site infection, which may be the source of the peritonitis. Module 2 Question 2 of 6. For each client finding, click to specify if the finding supports the diagnosis of peritonitis or end-stage renal disease, ESRD. Each finding may support more than one condition. Each column must have at least one option selected. The findings are BUN 46, creatinine 11.7, C-reactive protein 61.5, potassium, serum, 5.86, phosphorus 5.4, hemoglobin 10.6. WBC 14.22 by 109 cells per liter. Neutrophils 89%. Question 2 Answer the findings below supports the diagnosis of peritonitis, C-reactive protein 61.5, WBC 14.22 by 109 cells per liter, and neutrophils 89%. The findings that supports the diagnosis of end-stage renal disease, ESRD, are BUN 46, creatinine 11.7, potassium, serum, 5.86, phosphorus 5.4, and hemoglobin 10.6. Rationale: C-reactive protein is an inflammatory marker and is elevated in the presence of infection and inflammation. BUN, creatinine, and potassium imbalances are common in clients with ESRD associated with the inability of the client's kidneys to excrete waste products. Anemia is indicated by the low hemoglobin and hematocrit. This is a result of the kidney's inability to produce erythropoietin in clients with ESRD. Elevated WBC and neutrophil levels are diagnostic of infection. Module 3 Question 3 of 6. Drag the most appropriate word from the choices on the left to fill in the blank of the following sentence. The client is at highest risk for developing abdominal abscess, cellulitis, pyelonephritis, or sepsis. Question 3 answer is: the client is at highest risk for developing sepsis. Rationale: approximately 11% of ESRD patients with peritonitis develop sepsis. Sepsis is a general term used to characterize an immune system response to an infection. In sepsis, the chemicals from the body's own defenses trigger inflammatory responses, which can impair blood flow to organs, like the brain or heart. This in turn can lead to organ failure and tissue damage. At its most severe, the body's response to infection can cause dangerously low blood pressure, a sign of septic shock. The mortality from septic shock is about 33%. Module 4 Question 4 of 6. The nurse reviews new lab information. Microbiology. Type of sample: dialysate effluent. Preliminary visual report: gram-negative rods. Based on the new lab data, for each potential order, choose to specify whether the order is appropriate or not appropriate to include in the plan of care. The potential orders are: daily weights, blood cultures stat, peritoneal dialysis catheter care Q shift, IVF D5 1/2 normal saline with 20 milliequivalent per liter, potassium chloride at 120 milliliters per hour, calcium carbonate with meals, vancomycin intravenously, gentamicin intraperitoneally daily, enoxaparin subcutaneous daily, epoetin alpha injections. Rationale for not appropriate: IVF D5 1/2 normal saline with 20 milliequivalent per liter, potassium chloride at 120 milliliters per hour is not appropriate as clients with ESRD are oliguric or anuric, and this would place the client at risk for developing hypervolemia and hyperkalemia. Vancomycin is not effective against gram-negative pathogens. Unless the patient is septic, antibiotics should be infused intraperitoneally for peritonitis in clients with ESRD on peritoneal dialysis. Enoxaparin is not appropriate in clients with ESRD. This medication is excreted renally, so clients with ESRD cannot clear the medication, leading to a high risk of bleeding. Rationale for appropriate: a daily weight is needed to assess for hypervolemia associated with ESRD. Inflammation of the peritoneum associated with peritonitis may interfere with the efficacy of peritoneal dialysis. Blood cultures are needed to assess for potential bacteremia. Clients with bacteremia may need 4 antibiotics in addition to intraperitoneal antibiotics. PD catheter care is needed to treat the infection. The catheter may need to be removed and reinserted if the infection does not clear. Gentamicin is a good broad-spectrum antibiotic that treats gram-negative bacteria. Once culture results are received, the antibiotic should be adjusted based on sensitivity results. Intraperitoneal delivery is more effective than for peritonitis. Epoetin alpha is used to treat anemia associated with ESRD. In clients with ESRD, the kidneys do not produce enough erythropoietin to stimulate red blood cell production. Calcium carbonate, a phosphate binders must be taken with each meal to prevent the absorption of phosphorus from the gut. Keeping serum phosphate levels within the normal range will prevent serum phosphorus from binding with serum calcium, which lowers the calcium level. Module 5 Question 5 of 6. The nurse leads a team that includes an LPN and an unlicensed assistive personnel, UAP, and plans the client's care based on the most effective use of the team's skill mix. For each task, click to specify if the task should be performed by the RN, the LPN, or the UAP. The tasks are as follows: vital signs, dialysate exchange, daily weights, peritoneal dialysis catheter care Q shift, intraperitoneally gentamicin, peritoneal dialysis catheter care teaching. Question 5 answer. The RN scope of practice includes dialysate exchange, intraperitoneally gentamicin, and Peritoneal Dialysis Catheter Care Teaching. Rationale: the UAP provides basic care skills such as hygiene, and collects limited assessment data, such as vital signs and weights. The LPN can perform nursing care in routine nursing situations. They can provide non-complicated wound care. They cannot implement non-routine. Module 6 Question 6 of 6. The nurse teaches the client about peritoneal dialysis catheter care to help prevent future infections. Choose to specify whether each statement indicates the client understands or does not understand the teaching provided concerning self-care of the peritoneal dialysis catheter. The client's statements includes: before cleaning the area, I will wash my hands with soap and water and put on clean gloves. I should remove crusts or scabs at the exit site before washing the site. I should hold the catheter in place during cleaning to prevent injury to the skin. I should scrub the exit site vigorously with an antiseptic solution like iodine or chlorhexidine. I will put antibiotic cream on the skin around the catheter with a cotton tip swab every time I change the dressing. I will not use any creams with petroleum because they can damage the catheter. I will leave the exit site open to air or covered by loose clothing. Question 6 answers are: client statements that supports understanding includes: before cleaning the area, I will wash my hands with soap and water and put on clean gloves. I should hold the catheter in place during cleaning to prevent injury to the skin. I will put antibiotic cream on the skin around the catheter with a cotton tip swab every time I change the dressing. I will not use any creams with petroleum because they can damage the catheter. Statements that need further teaching includes: I should remove crusts or scabs at the exit site before washing the site. I should scrub the exit site vigorously with an antiseptic solution like iodine or chlorhexidine. I will leave the exit site open to air or covered by loose clothing. Rationale: clients should not pick or remove crusts or scabs at the exit site before washing the site. This could tear the skin and increase the risk for site infection. Clients should clean the catheter exit site with a liquid antibacterial soap and a clean cloth. Antiseptics can dry and crack the skin, increasing the risk of infection. The exit site should not be left open to air. It should be covered with sterile gauze, which should be changed every time the site is cleaned. That concludes the case study. Here is a bonus standalone Bowtie question.
Bowtie case study. A 39-year-old male came to the emergency department with shaking chills, and temperature reported as 101.2 Fahrenheit, 38.4 Celsius. Weight, 109.1 kilogram or 240 pounds. No known drug allergies. Client has history of end-stage renal failure secondary to heroin nephrotoxicity and has been on hemodialysis for approximately 7 months. Current assessment includes: client has a left upper arm arteriovenous AV fistula with a positive thrill and bruit. The AV fistula is red and inflamed. Lab sent. Vitals taken at 1500 R. Temp 39.2 Celsius or 102.60 Fahrenheit. Heart rate 104. Respiratory rate 18. Blood pressure 150/92. Pulse oximeter 95% room air. Pain, AV site, 6 out of 10. 1600 vitals are: temperature 40.2 Celsius or 104.40 Fahrenheit. Heart rate 121. Respiratory rate 26. Blood pressure 100/64. Pulse oximeter 90% room air. Pain, AV site, 8 out of 10. Based on the client information, complete the diagram by choosing a response from the choices below to specify what condition the client is most likely experiencing, 2 actions the nurse should take to address that condition, and 2 parameters the nurse should monitor to assess the client's progress. During NCLEX exam, you will be asked to drag and drop the appropriate answers to their designated boxes. You may pause the video here. Bowtie answer. The client is most likely experiencing septicemia. The actions the nurse should take to address the septicemia includes administering oxygen and administering broad-spectrum antibiotics intravenous. The two parameters the nurse should monitor to assess the client's progress are urinary output and pulse oximeter. Rationale: the client has evidence of a skin infection at the AV site. The drop in blood pressure and pulse oximeter readings suggest the client has septicemia and is developing septic shock. Antibiotics and oxygen are most needed. The nurse should monitor the client's perfusion by watching for changes in the pulse oximeter and blood pressure. Urine output is not a good measure of perfusion in a client on dialysis.
Thank you for clicking. Like, share, and please subscribe for more videos. Leave a comment on how you are doing and let us know what future videos would you like to see.